Oh, there she is. Start. Good morning. Thank you all for being here. This is, I think, the second lecture this year in our STD Prevention Science Series, which is organized by American Social Health Association, American STD Association, American Sexual Health Association helps us with the operational issues with this lectureship, and our division. It gives me tremendous pleasure to present to you Dr. Aron Janssen, who many of you know and remember from the plenary talk he gave during our STD Prevention Conference last year. Aron is a clinical assistant professor of child and adolescent psychiatry and an attending physician at the NYU Child Study Center. He is the founder and clinical director of the Gender and Sexuality Service and co-director of the NYU Consultation-Liaison Service. And he is the chair of the LGBTQ Advisory Council at NYU Langone Medical Center. His primary academic focus is on gender and sexuality development and gender variance in childhood and adolescence. I can add to that he is the most centered, even-keeled, well-controlled prevention science series speaker we have ever had since the beginning of the lectureship. Yesterday, he had to write to me around 4 o'clock, I think it was. Oh, my flight is delayed for 2.5 hours, so I can't do dinner with Gail and Sevgi. So we were all very sorry, it will go well from this point on, etc. And then he called me again around 8:30 saying the hotel has never heard of me, there is no reservation under my name. So that was the disaster. I mean, the lack of dinner, okay, but the no name at the hotel, I was like, okay, how do I deal with this? How is he dealing with it? Well, clearly, he's a professor of psychiatry, and he earned it. I know he earned it. Here it is.
Thank you. Thanks, everybody, for having me and for the warm introduction. And I'm happy to be here, and it was a lovely night at the hotel when it was all worked out. So today, I'll keep my eye on the clock just to make sure that I don't go over, because I could speak about this topic for hours and hours and hours and hours. One of the joys that I have in my work is that I get to also teach at the undergrad level. So I'm used to people interrupting with questions that are seemingly tangential to the topic, and I welcome it. It keeps it much more interesting, keeps me engaged and focused on kind of what the needs are in the room. So I know that we have folks who are listening on Skype. So if there are questions that are burning and we kind of want to ask them and you want to interrupt, please just come to the mic so that the folks who are listening remotely can hear your question. So I'm going to talk today about transgender health, specifically through the lens of child and adolescent development, and the impact that's going to have on overall mental health in particular, but kind of medical health less specifically. So the way I start kind of most of these lectures, and I apologize if there's going to be a little bit of some repetition from what was in the plenary last year, but I think it's important to kind of get us all on the same page, at least in terms of terminology and thinking. Because I think by and large, for most people who live without a minority experience in their lives, kind of their experience is often universalized, right? Unless you have an opportunity to think that this is a different experience for me, often there's a lot of assumptions that are made about the universality of one's developmental trajectory. So when it comes to gender feels like this very kind of concrete thing, right? It is either you are a boy or you are a girl. But there's a lot of folks for whom that is not so straightforward of an experience. And so in the field, as we think about kind of components of gender, we like to parse things out. put things in boxes and then break down those boxes. We want to think about what the various components are. So we think about it in kind of a 3-component system comprised of birth, sex, gender identity, and gender role. Now, birth sex is kind of the first piece, and it's the one I always start with. And the picture I'm going to show is a picture that I typically will show giant full screen when I'm giving talks, in particular to parents or teachers. It has a way of waking up the group, and you'll see why. We have this picture here, top right. We are taught from a very, very early age, right, that there are 2 categories of birth sex. Right? It is the easiest box that we have, the M box or the F box. But what are we looking at here? Right? When we look at this picture, I mean, what exactly are we seeing? If you were to describe this structure, what would you describe? What would you see? Right? Is this a penis? Is this a vagina? It's a baby. I mean, I can tell you that much. Right? The reason I start with this picture is because so often the idea of gender as a spectrum gets dismissed as this kind of very Bay Area leftist concept. The reality is, if we look at even something as structural as the genitalia, there is so much more variety than we ever want to talk about. The levels of intersex individuals, if we kind of define it kind of relatively liberally, it's about a 1 in 1,000 prevalence rates for some of the various intersex conditions, but nobody's really talking about it. So it's not something that we're very much aware of. And there's no card at Hallmark, congratulations on your healthy intersex baby. Right? Either it's a boy or it's a girl. But the reality is that there's a lot more fluidity and flexibility even in how our genitalia is structured. It's a whole different process that I'm not going to go into today, but it's a really fascinating developmental process how the internal and external genitalia form, but they form very differently and independently of one another. So that's kind of birth sex. So we break that piece down. So genitalia does not necessarily equal male or female, which brings us to gender role and gender identity. So gender role was a concept that was termed by this guy, John Money, who was practicing out of Johns Hopkins in the 1960s. And he described it as kind of the public presentation of gender. Right? It's what we do to perform gender. It's how we define our gender within a cultural or social context. Right? So in our country right now, pink means girl, blue means boy. Interestingly, it was exactly the opposite back in the early 1900s. There's a Lady Home journal from 1913 that talks about how pink should be reserved exclusively for boys because it is a aggressive, warm color, and blue, which is softer, should be reserved for girls. So obviously these things change over time, but the idea of gender role, right, that we have these natural draws towards things based on gender has been a validated concept over time. There does appear to be a biological construct to this, right? Even within monkeys, you often see male monkeys, if you're given 2 blocks, will be much more aggressive with the blocks than girl monkeys who will be much more relational in their play. So there are some biological determinants of gender role, but gender role and gender identity are 2 separate concepts. Now, we learned a lot about transgender health and about gender identity development from some incredibly tragic experiences. And we have a lot within medical health, but specifically within mental health, to apologize for the work that we've done. This picture here on the left, I guess it is, left, this is kind of a very famous case that kind of led to John Money's kind of ultimate downfall in terms of public opinion of him within his science. And this is the John Joan case. I don't know who has heard of the John Joan case, but it's a really sad story. So this was a fraternal twin set born, 2 male infants assigned at birth. And for whatever reason, they decided that they were going to do a circumcision via cautery. And if you are not a medical person in the field, this is a burning instrument. And they burned this kid's penis off. So at the time, what they said was, a healthy sexual life is important, which is true. And if you don't have a large enough penis to have vaginal sex, you're never going to have a healthy sexual life, and you're going to be destined to kind of be sad and depressed for your whole existence. And John Money saw this kid, and it was an opportunity to test this theory that he had, that how we treat kids influences how they see themselves. So for John Money, his thinking was gender role defines gender identity. Right? And we see this, actually. I actually just I have a 4-month-old little girl at home, and it's pretty remarkable, the differences in how my daughter is treated versus my friends who have a son. And there was this great BBC documentary that took the same babies, put them in a pink outfit, and then put them in a blue outfit. Didn't change anything else, and it was the exact same people. They had no idea it was the same baby just because of how the child was dressed. Right? How they talked to the baby was different. The content of what they said to the baby was different. The way they handled the baby was different. The tone of voice they used was different. What they imagined for the baby was different, all based on their perception of this child's gender. So John Money said this has a profound influence on how people see themselves. And so if we allow this kid to be raised as a girl, we treat this kid as a girl, we dress her as a girl at the time, she will feel happy, and she will have a healthier life. And we can do things like the hormones and the surgeries to make her body align with her identity. Well, the reality is that this kid always felt different. He never felt exactly like a girl. When he discovered in his teens that this was the case, that he was actually born male, later in his teen years and early adulthood, he opted to transition back to becoming a male and ended up committing suicide in his early 30s. It was, in that case, an example, right, that there is something that is more inherent, more unique, more universal than just how you are treated that defines how you see your gender. Right? I would imagine that most people in this room can think, just have an experience, I am a man, I am a woman, I'm somewhere in between, and that it's not something you have to question or think about. Right? That's the essence of what gender identity is. Right? It is this innate concept that we are all developing over time, and we'll get into how it develops, but it is separate from gender role. Does that make sense? The question is, how do we know what gender identity is? So if you have that child who's born with this genitalia, how do we know what those child's gender identity is? Right? We could ask. I don't expect the genitalia is going to answer. Right? We have to ask the child. Right? We have to understand. We have to ask. And it takes a little while before that happens. Now, how does this interlap with sexuality? We're going to go into this later, but sexuality, again, like working at the CDC, obviously, this is kind of bread and butter, right? That behavior does not equal identity. I think we lost a lot of opportunities within HIV prevention by kind of not understanding that concept soon enough. But that there is this difference between kind of that piece of sexual attraction that is immutable, right? And there's clear genetic predispositions towards sexual orientation versus the behavior. And as a child clinician, kind of this idea of sex anyway is incredibly complicated. Right? What sex means to each individual person, not to mention each individual child, is so different. And so we have a lot of clinicians who are asking kids if they're sexually active. Well, what the hell does that mean? Right? Nobody knows what sexually active means. Everybody's got a different definition, including Bill Clinton, right, and Monica Lewinsky. Right? That joke does not go over when I'm talking to teens about this. They're like, I don't know what you're talking about. Right? And then, of course, the identity piece, again, this is how I consolidate it. This is who I'm attracted to. This is the behavior that I engage in, and this is how I describe it and consolidate it in my identity. Right? It's actually kind of interesting. Rates of kind of same-sex behavior have actually declined as rates of sexual identity of people self-identifying as homosexual have gone up. Right? There's less room for experimentation behaviorally because now it is kind of always associated with this identity as opposed to just this behavior that was often quite common, which is fascinating. So this kind of intentionally messy slide that kind of puts all this together, right? For whatever reason, as a concept, this is very easy for children to get and very hard for adults to get. Right? That gender identity, sexual orientation are separate concepts, but obviously that there's interaction, right? So you can be born male, female, intersex, identify as male, female, or other, and be attracted to any or all of the above. Right? So this is not a neat diagram, But if we ask people from within the community to create a way of articulating kind of the beautiful diversity that this is, you get the gender unicorn. Right? This was put together by folks within the community themselves as a way of really kind of putting together in one kind of very cute graph ways of thinking about this, right? The gender identity, one can identify both female and male or neither or both, that you can express your gender in a separate way from how you identify, right? That you can be physically attracted and emotionally attracted to all sorts of different kinds of people. So I work in Manhattan, in downtown Manhattan at that, and I see a lot of really progressive kind of kids. And there's so many kids right now who are just all over the map in terms of identity. And there's a lot of environments within at least the city I live in where that is totally normalized, that it's completely okay to be genderqueer or agender or transgender or a feminine boy and have all sorts of various kinds of attractions. But as we're thinking practically, when you have somebody who is assigned male at birth who identifies as a girl, and you have somebody who is attracted to that person, and we have these kind of blunt instruments in asking kids about who they're attracted to sexually, it just falls apart because it gets so much more complex. So from a public health and epidemiologic perspective, it's actually really challenging to figure out how to capture this. From a psychiatrist perspective, it's amazing because I just get to have all sorts of really interesting discussions and hear all sorts of stories. So we're going to go over development. We're going to talk about prevalence rates. We're going to talk about mental health and medical needs, experience of healthcare, and then skipping ahead because I'm sure we'll run out of time for all of the slides. All right. So this is going to be the interactive piece because it's close to lunchtime, so everybody sleeps and gets tired. So I'm going to make everybody raise your hand, and if you're listening on Skype, do this virtually, please. So if I'm going to break this down into gender identity, sexual orientation, or sexual behavior, the question is, which comes first developmentally, right? So I need an answer. Nobody's allowed to abstain. All right, so if we're going to say which comes first, who says gender identity? Okay, so for those in Skype, it's about half the room. Who says sexual orientation? Okay, slightly fewer. And sexual behavior? Probably about a third. So we have gender identity as the clear winner, with sexual behavior being number 2. So I remember when I would have professors who would ask these questions, and then the answer would be, well, there's no real answer, and everybody gets super frustrated. That is not the response here. There is actually a real answer, and it is very clear and very explicit, and the third one is correct. Sexual behavior, far and away, the very first to show up. It's actually ultrasonographic evidence of babies masturbating in utero. By 20 weeks of gestational age, all of the nerves, all of the body parts that are there are functioning. So that's what happens, right? It's interesting because we put our own adult ideas of sexuality onto these kids. It's not like the kids know that their penis is different than their finger. Kind of culturally or socially. It's a part of the body, and it just happens to be a part of the body. When I touch it, it feels good, right? So as kids get more manually dexterous, sexual behavior goes up. So this is masturbation. Right? I had a kid that I was following during my neurology rotation when I was in medical school, where we got to tell the family that, no, your daughter does not have a seizure disorder. She's actually having an orgasm, right? Which is a lovely diagnosis to be able to give, right? She was flushed, she was shaking, eyes would roll back in her head. I mean, you can understand why the parents would think. But this happens. Something happens around age 4 or 5 where all of a sudden the sexual behavior starts to go in decline, right? Any guesses? Right? This is school, right? This is all of a sudden you are shamed for doing this. This is not appropriate to do here. Interestingly, girls are shamed, and they're 3 times more likely to be told that what they're doing is sinful or morally wrong by their parents than boys are. Does it have long-term effects? Yes, probably. Gender is next, gender identity. And gender identity is this interesting 3-stage concept where you develop a basic sense of gender identity first by age 2 to 3. right? So kids at age 2 to 3 can say, I am a boy, I am a girl. Some transgender kids by age 2 to 3 are already very clear about their identity, right? So somebody assigned male at birth can say, I am a girl, right? Why didn't God make me a girl? God made a mistake, gave me these extra parts that I didn't want. But that's not common. It's much more common for it to happen later. Gender stability is the next stage, and gender stability and gender constancy relatively close. And how we differentiate this, we can very easily test this within a clinic setting, where you just have a kid come in, you have a doll, say it's a girl doll because she's wearing a dress. You ask the girl, the child, is this a boy or a girl? It's a girl. Why? Because she's wearing a dress. Great. You change the doll in front of the child into pants, into kind of a more male appearance, and you ask the child again, is this a boy or a girl? Well, it's a boy, right? The gender is directly correlated with the role at age 4, right? Kids have a belief that their gender is kind of this magical thing that just goes back and forth throughout time. When a kid reaches gender constancy, then you turn that question on them, right? So if we dressed you in a dress, would you still be a boy or would you be a girl? Before they reach constancy, changing your dress would make a child into a girl. But once they reach it, they understand, oh, for me, no. Right? For this doll, yes, but for me, no. And when they finally reach constancy, they recognize that gender is stable for all kids, right? That it's not going to change based upon appearance. And it's around this age, 5, 6, kindergarten, first grade, where I start to see kind of the biggest cohort of my childhood referrals. All of a sudden, this is when the kids start to get cooties, right? And where kids who were assigned male at birth who want to hang out with all the girls are all of a sudden rejected from their peer groups. And this is where we start to see kids internalize that sense of shame and start to kind of feel embarrassed and hide some of their interests that might be variant. Now, sexual orientation is the last to form, right? And this is probably about 2 years prior to puberty onset is when folks mostly start to be able to articulate a sense of self in terms of differentness of attraction. For trans identity, this is throughout the lifespan. Right? There's no one way of being transgender. Right? And if you were just to look at the media, particularly around transgender youth, you would think that every kid knows by age 3 and it's very insistent, persistent, consistent, kind of the parlance of the times. But for those of us who are actually doing the work, that's only about half the time or less. Much more often we see an emergence of a trans identity around the stages of puberty, that there's something more subtle in early childhood, but that when puberty comes, there's a sense of differentness that gets articulated when they get exposed to the concept. So a not uncommon story is for parents to say, my kid went to the Pride Parade and all of a sudden they came back transgender, or they went to this camp and all of a sudden they came back transgender. And it's actually relatively true. For a long time and for a lot of people's experience, it's this sense of otherness or differentness that they could never clearly articulate. And as soon as you have the concept or the word, all of a sudden they're like, yes, this is it. I didn't know what this was, but this is exactly it. And it's very reassuring in a lot of ways to those kids. As we talk about prevalence rates going up, I think that's probably a big piece of it. Right? As more people are exposed to the concept, more people are able to come forward earlier. I'm going to skip this slide because it's really messy, but all of it says basically is that there's likely some biological components, but there's so little data that we don't really have anything to say about it. Into development, there's the controversy, and these 2 slides really are about the biggest controversy in children's mental health for transgender youth at this point, which is speaking to the importance of definitions and how we think about gender identity and how we choose to define it. So in the 4th iteration of the DSM, the DSM-4, being transgender was called gender identity disorder. So the identity was pathologized. And now it's called gender dysphoria, so it's the distress about the identity that's pathologized. It's still problematic, but it is what it is. One of the issues in childhood gender identity disorder was that the diagnostic criteria were incredibly broad. you actually didn't have to affirm or want to be or feel that you were the opposite gender in order to meet criteria for gender identity disorder. You just had to have a lot of cross-gender interests, play, behavior, or peer preference. Right? So for a lot of kids who were tomboys, or there's not really a good alternative term for feminine boys, right? These are the sissy boys, is what the not so nice term was used, would fit in this category. Right? So if you were a little boy who liked to wear dresses, who liked to hang out with the girls, who preferred My Little Ponies to He-Man, right, you could conceivably qualify for this diagnosis even if you didn't actually want to be a girl. And so we followed these kids over time, and this is the data that we have. And the data that we have says that those kids, if you follow them through adolescence, about 75 to 95% of them, by the time they hit adolescence, no longer met criteria for gender identity disorder. And a vast majority of those kids ended up being gay or lesbian. Right? So that there's this interesting piece that sometimes a later gay identity presents as variations in gender role in childhood. Right? So if you have a tomboyish girl, you are more likely to grow up to be a lesbian than you are to grow up to be a transgender man, if that makes sense. Right? The issue being that that was a very non-specific diagnosis. Right? So gender dysphoria in DSM-5 has made it much more specific and much more constrained. So we'll see in another 20 years kind of what this data actually looks like. But what I would argue would be kind of a new proposal or a new way of thinking about it, that gender variance, which I've included in this slide, is kind of just this yellow color, and I apologize for the colors. I don't know how to change them on PowerPoint, but they are not attractive colors. Gender variance is thought of as kind of this yellow box, and it's a non-specific symptom, if we want to call it that. Right? Having variability in how you express or experience gender is not predictive in and of itself. If you are a transgender kid, if you are that kid at age 2 or 3 who says, I am a girl, yes, you are going to have gender variance in childhood, and that will persist into adulthood. If you are not transgender, so I'm a not transgender person, but I actually had a lot of kind of gender variant type behaviors as a kid. So I had some gender variance, but I was not transgender, it never was. So that's a different developmental trajectory. And then we see, if you listen to kind of the Caitlyn Jenner interview, right, a very common trajectory where you don't seem to have a lot of transgender or gender variance in childhood. Often that gets pushed away. And it's not until later in adulthood or later in adolescence that it starts to come out. Right? Our goal within this field is really how do we understand and predict who these kids are going to be? Because if we know that there's going to be a transgender adult, we know that supporting them in transitioning earlier rather than later leads to much better outcomes. So how do we kind of dial that back and start to make predictions based upon insistence, based upon the intensity of the distress, based upon the age at which social transition is kind of pushed forward? These are the things that we are now looking at to see, can we start to make these predictions? As an individual clinician, it's much easier. Right? The individual kid that you're working with, it's not kind of a mystery. The kids very, very much lead the way in this. They're like, you try and cut my hair, or you try and not let me cut my hair, I'm going to kind of go into the kitchen and take the kitchen clippers and do it myself. Like, we've had kids that have tried to cut off their penises at age 4 with nail clippers. Right? These are not necessarily subtle signs that we're picking up on. It's only when you look at the population-based data that it starts to get a lot muddier. So, what is the prevalence? How do we even know? How many people here have been asked about their gender identity and whether it aligns with their birth sex in any kind of setting ever? For those listening on Skype, there were 0 hands, which is not a surprise. Right? This isn't something that we ask about. Thankfully, I hear that this is changing, right? That we are going to start doing asking some of these questions, and some of them are starting to become incorporated in the large national surveys. So most of the data we have right now is from Holland and from Northern Europe. And these are kind of the numbers that we have based upon their data. So that an identity, a transgender identity in children is about 1 to 2%, that in adolescents closer to 0.2 to 0.4%. and that there is not a terribly different split based upon natal gender. This is different from the old data where there was a very clear gender split in childhood gender identity, where folks coming to these gender identity clinics were predominantly natal males, so people assigned male at birth, right? Which is probably a reflection of kind of where these clinics were. So anyway, if we look at the actual DSM, and the DSM still makes the estimate that there's about 0.005 to 0.014% of the population, right, which is roughly 1 in 10,000 to 1 in 30,000, right? I think we probably all, I would hope most people have met a transgender person or know of a transgender person and know that these numbers are woefully underestimated. It probably is much closer to the data that we have coming out of Europe than the data that's quoted from 1993 and the 2014 version of the DSM. So we do have some US-specific data. So the Williams Institute just released their 2016 update that actually uses the CDC's Behavioral Risk Factor Surveillance Survey, which asks the question, do you consider yourself to be transgender? It's a relatively straightforward question, and it's a perfectly valid way of asking about it. As it turns out, people can self-identify their gender identity very accurately. We don't have to go through all of these kinds of tests and concerns. Are you a man? Yes. Great. Right? When somebody asks me that question, they just accept it. Right? But the data that we have presumes and does support the idea that transgender people have just as much capacity to self-identify their gender as anybody else. So if you ask the question, are you transgender? Yes is a valid response. And these numbers are much, much higher than the 0.05% numbers that are quoted right now in the DSM. This is 0.7% in the young people, 0.6% in 25 to 64, and 0.5%. Right, so 100 times more frequent than the DSM is estimating the prevalence rates at when we finally have had some sort of national survey data. Right? So these are very big increases, and I think there's a lot of us who are trying to understand why that is. Interestingly, I don't think I have it in here, but oh, here it is. In Georgia, since this is where we're at, 0.75% of Georgians identify as transgender, and DC actually has the highest prevalence of transgender identified individuals at 2.77%, right, which is huge. When we get into HIV rates, it's not surprising, actually. So specific health needs of transgender folks, it's kind of really sad outcomes for transgender people in terms of their experience of health care. 25% of transgender folks are actually denied care by physicians. 50% have faced harassment and often have to actually teach their own physicians about their care. The 2015 Williams Institute data showed transgender population probably around 0.3, which was roughly equivalent to the number of folks who have red hair or diabetes type 1. Right? So this is just to kind of concretize it. And we've all had like 100 hours of education about diabetes type 1 in medical school, but zero. The average medical student gets 0 hours on transgender health. But for whatever reason, physicians often feel like they are empowered to not choose to learn about this aspect of care. And so when transgender patients come to see them, oftentimes they just are encountered by ignorance, unfortunately. But the needs are very clear. Right? And kind of the 3 domains that are different about transgender health, right? Social transition and support. So that means living in your desired gender role, medical interventions and care, which are defined by these two, this WPATH standards of care and the Endocrine Society guidelines, which are being revised now, both of them actually, and then the surgical interventions. And we'll go a little bit into these. So social transition and support. And for kids, this is like all we're doing. Right? For a prepubertal child, there is nothing else to do other than social transition and support. Right? This is about building community networks. This is about building family support. And this is about supporting and making sure that folks have access to equal opportunities of employment. Right? It used to be that the National So Medicaid and Medicare specifically denied coverage for gender identity disorder. It was one of two things that was specifically barred from coverage, the other being abortion services. And so there was no access to low-income people to transition-related care. And then, of course, we know that trans people are fired from their jobs and not hired, so they're going to be much more likely to be in that position anyway. We actually did a pilot survey looking at neighborhood-based determinants of health among trans women in New York City, and we had this fascinating pilot group where out of our just 20 pilot participants, over half of them had bachelor's degrees. The average income of our sample was $12,000 a year. Right? So we have a highly educated sample who's nevertheless not able to access effective employment. Right? So these things matter. In terms of supporting folks, when I'm thinking about an intervention for somebody with depression, often it's cognitive-based therapy, an antidepressant medication. For a transgender person, it's doing those things and making sure that they have access to employment, making sure that they know a community of people that might be able to hire them. For youth, this is school. Right? And obviously there's a lot of controversy right now in the field. The Supreme Court decision that was going to come up with Gavin Grimm was put on hold. But we know that this has profound influence on children's experience, particularly in school. And we don't have any data because the YRBS does not have any transgender specific questions right now, but from the LGB and generally for everything that affects LGB students, it's going to affect the T students significantly more. And you see that 12% of LGB folks skip school because of fears of safety. Almost 20% of LGB folks were forced into unwanted sexual intercourse. These numbers are going to be higher for transgender people, for sure. So what does that do to a kid? Do kids with gender variance or gender dysphoria have more mental illness? You would expect the answer to be obviously, right? Because they are exposed to minority stress, which is a concept from Alon Meyer that says your day-to-day experiences of being rejected for who you are has negative impacts on your social and psychological health. It makes sense. We would expect there to be increased rates of depression, increased rates of anxiety, and we see that. But if we actually compare it to a sample group, so kids with ADHD, for example, the number of co-occurring rates of psychiatric disorders are equal. So it's not that necessarily being transgender predisposes you to more inherent psychiatric disability. One exception to that is autism spectrum disorders. We do see, and there's been a number of groups, including mine at NYU, that have confirmed this, that there is a bidirectional relationship between autism and gender variance. That folks who have autism are more likely to be transgender, and people who are transgender are more likely to be autistic. There's a lot of interesting theories, and I could go into a whole 3-hour talk about that in and of itself, but suffice it to say, it's fascinating. And when you have a kind of a disorder or a neurological difference that makes you interface with the world differently, it's not 100% surprising to me that they have a different concept of how gender should be expressed and experienced. This is a little bit of a busy slide, really just to look at psychiatric co-occurrence. And I'll kind of zoom through this, which is basically just to say that, yes, we see increased rates. It's likely that if there were minority stress were not an issue, that these rates would go down. But the one piece that's not on the slide, but if you Google, and particularly as a parent, what will happen to my transgender child, the 40% suicide attempt rate comes up. Right? And that's a public health crisis, right? Particularly if we're thinking that the rates from the Williams Institute are correct, and we're seeing about 0.7% of young people identifying as transgender, and of that 0.7%, 40% of them have attempted suicide. And that's data that has actually been replicated across several studies. That is an issue. Right? That's something that we need to address and think about. What do we know helps? Well, the one thing that really is clearly helpful is this the concept of acceptance of one's family. So the data here, we have a Canadian research group that did this little nice infographic, and this is coming out of Caitlin Ryan's group in the Bay Area, that basically is very clear, and it's good research. The Canadian group is fair research, but the Caitlin Ryan's group is good research that really points very clearly that acceptance leads to protection for transgender youth and LGBT youth. The kids who are accepted by their families are much more likely to not be in that 40% suicide attempt cohort. And the opposite is true. If we looked at that 40% cohort, a majority of those folks were from high rejecting families. And so that's an issue, particularly when you have folks like me who are providing care, but I run our gender and sexuality service. Right? So I'm not going to get the families who are rejecting. They're just not going to come to me. And so it's a problem. And a lot of these folks are going to be coming from minority families as well, and families that don't have access to good insurance or can't afford self-care or self-pay. Right? There's a lot of issues that we still have in place. So the question is that this is a changing world. Right? There's so much kind of doom and gloom that gets focused on transgender youth because of these kind of very terrifying rates of psychopathology that we see. But at the same point, right, we're seeing, Jazz Jennings has a reality TV show about her experiences growing up transgender. Like, surely the increase in media attention that's positive about this has got to have some sort of effect. Well, certainly we are seeing much more kids who are socially transitioning earlier and earlier. So living how they feel from an earlier age. And we are now, through the Trans Youth Project that's run out of University of Washington by Christina Olson, she's following a cohort of kids aged 3 to 12. My plan is to follow them throughout their early lives into early adulthood who have transitioned. And what she has found, these are families who, by definition, are going to be accepting families. And what she has found in those kids is that there are no increased rates of depression. There are no slightly increased rates of anxiety, but no increase in depression compared to their siblings or compared to age-matched controls. Right? So living in a family that allows a kid to be who they are actually has significant long-term impacts. And kids who are not depressed in childhood do better in school, they make more friends, they're more likely to be independent. So we'll see. We'll see what the outcomes are in 20 years for these kids, but it's certainly looking positive at this point. In terms of the medical stuff, so for kids, the big question is puberty blockers. So these are medications that once you hit Tanner stage 2 of puberty, so the initial stages of puberty, you can start a child on puberty blockers, which halts the progression of puberty. They are reversible, and so if you stop the blockers at any point, kind of your natural puberty will resume. Right? These are very expensive, and most insurance companies will not cover it. So this is something that's given access to a very select group of folks within the U.S. Across Europe, these are standard of care, so everybody has access to them. But in the U.S., it's really case by case, and that's likely to change. There were some support, and there's certainly a positive movement in this in the last 4 to 8 years, but it's unclear how this will actually stand with the new legislation that's on the books. Why do we wait for Tanner stage 2 of puberty? This brings us back to that developmental chart and when sexual orientation starts to come in. Right? If we posit that a lot of gender variance in childhood actually leads to a gay or lesbian identity, we have to wait in some ways until that identity can start to take hold before we know for sure and before we want to make any permanent changes to the body. Puberty blockers kind of allow that time to continue to think through and consolidate the sexual identity and the gender identity. But you wait until that second stage of puberty because puberty in and of itself is probably our best diagnostic tool. Right? When puberty starts to come and the body starts to change, right, for kids who are clear, it is the worst thing ever. Like, this feels terrible, my body is changing and I hate it. And for others, it's like, oh, that's not so bad. We're getting better at predicting who's going to be who, so it's kind of less in practice than it is in theory, but we do see it. And when you have a kid who's got access to puberty blockers, the need for interventions later in life goes way, way down. And when we talk about the controversies of this treatment, those in the field and in the Endocrine Society, all of the professional organizations that have any kind of horse in this race, it's just a non-issue. But a lot of kind of the media stuff, it's like, are we changing kids' trajectories? Are we doing something that's permanent? Are we altering the course? Well, puberty is a permanent intervention. Right? These hands are always going to be this size. Right? My Adam's apple is always going to be here. This facial hair, the body hair that I have, it's never going away. Right? To be able to kind of remove that takes an incredible amount of effort. Puberty is a non-neutral intervention. And it's important to remember that when we're advocating, because really allowing time for kids to consolidate this sense of self and take an appropriate next step forward, because things like hormones, things like surgery have been clearly demonstrated to have positive impact on mental health outcomes, social determinants of health, long-term disability, et cetera. So when a kid gets to then 14, 15, 16 is generally the age that's recommended, then cross-sex hormones and kind of androgen blockers are engaged, right? So testosterone or estrogen. Your body doesn't care kind of how you were born, what your genitals look like. We all have estrogen receptors, we all have testosterone receptors, and we respond the same way that we would. The body doesn't care at all how you were born. And so the secondary sex characteristics continue to develop. It's important, obviously, to have conversations with the folks that you're working with, but they're effective and they're generally safe. And then routine medical care. Right? So folks who are trans, higher rates of cancer, higher rates of liver disease, higher rates of sexually transmitted infections, higher rates of heart disease, because there is no routine and preventative care in this population. If you have to go, we ran a focus group at our institution of trans folks to get a sense of their experience of care within our institution. And the one that stuck with me the most was a transgender guy who was going to the dental school to get a cavity filling. Right? Found out that the dentist did, the dental student, I should say. Hopefully maybe the dental student learned something while they were there, but the dental student, when filling this guy's cavity, saw on the form that he was on testosterone. And while he was in the dental chair, I mean, can you imagine a more vulnerable space than that? This guy was asking the transgender man about his clitoris and about his genitalia, all the while like in this incredibly vulnerable space. Guaranteed that that guy has not gone back for dental care in the next 10 years. Right? That happens all the time. And it's not like that dental student was malicious, just completely ignorant, but created a space that was incredibly unsafe for this kind of patient. Right? So if that's going to be your experience of medical care, it's not going to be particularly likely that you're going to seek it out. So we do see all these kind of downstream effects of that. HIV, and I apologize for the busyness of the slide, but this is actually copied from the CDC website in terms of rates, because it's really quite notable. Right? Those who have been doing kind of more specific work around HIV in trans populations, the rates of HIV among transgender folks in the US is 40 times that of the general population, even higher among trans women of color. Right? If we're going to consolidate all of that data and all that text, basically that's it. And it's kind of horrifying. It's more than kind of horrifying. But it's interesting in terms of how we collect this data. Most of the research in terms of sexual risk is around MSM. How do we categorize a transgender woman who still has a penis and is engaging in penile-vaginal sex or penile-anal sex? Right? How do we capture that? It's really hard, and I will tell a story about my own kind of lack of efficacy in this. I had a transgender boy that I was treating who expressed interest only in girls. Come and find out, right, a lot of people's kind of sense of self sexually will evolve as they transition, particularly as they kind of break down these barriers. And in the community that this guy was in, girl meant something very, very different than my idea of girl, and I'm in this field. So the girl that she was dating still had a penis, and they were having penile vaginal sex, because the patient I had still had a vagina, right? I hadn't been doing a lot of education around pregnancy or around STIs. This kid got vaginal herpes, right? Because I had assumed something about this kid's sexual practices based upon my own preconceptions. And so for the public health folks, it's like, how do we actually capture this? How do we really parse apart, like, what does gender actually mean in these settings? I know we're running close to time, and I want to leave a few minutes for questions. Surgery is beyond the scope of this. I would just say that I felt like I finally made it in this field when I got trolled on the internet because of a quote that I had that was supporting gender-affirming surgery for somebody who was on Medicaid in New York City, because it works and it's helpful. Anyway, so referral rates are going way up. We're seeing more and more of these kids. We don't have a ton of data. We need to collect it. We need to have folks who are kind of very good at seeing these kids longitudinally. And we need to teach researchers, we need to teach clinicians, we need to teach teachers, we need to teach families how to be more affirming and competent in their care. So I will leave it there so we have time for questions. And this is me, so thanks so much.
Hey there, thank you so much. This is fascinating. I have one of the undergraduate questions that you mentioned earlier.
Great.
So this morning we were talking about your lecture here, a colleague of mine and I had brought up that back in the early 90s there was a movie and actually a book that preceded that movie called Trainspotting. Some of you might be familiar with it, talking about heroin use in Scotland. There was a scene in that movie where the main character was at a dance club there in Scotland, and he was sort of watching who was pairing with whom on the dance floor. It was men with men, women with men, and then men with women. And he sort of said, you know, in the future there won't be blokes, there won't be birds, we'll all just be wankers. And I thought, wow, that was 25, nearly 30 years ago, and he said this. So my question to you, and you have brought up that in Manhattan it's actually kind of the cool, hip thing to do to question your sexuality, to come out as maybe transgender. Has this been around for like 100 years and we've just been ignorant of this? We've been probably suppressing this information?
Yep.
Or the prevalence has been there for a long time and we just haven't done anything about it?
The quick answer is yes.
Okay.
In every kind of recorded society that we know, there's kind of clear evidence of trans identities. In every religious kind of text, there's some kind of hints of that. I think what we can look at, I was actually just at this really interesting lecture about transgender in the Hasidim community, in the Orthodox Jewish community in New York. And you can kind of point to that, where there is a large community of folks who are transgender identified that are in the closet, because to identify as who you are would be to lose everything. So those folks have existed forever. Most of the history that we've had in the U.S. is that if you are going to identify as transgender, you are going to lose everything. And so there's very little reason to kind of affirm one's sense of self. Are the prevalence rates as high back then as they were now? It's hard to say. I think probably more folks who are on the spectrum, like if we're thinking about it like a 0 through 10, if you're 10, you're going to transition. If you're 9, probably going to transition. In the last 50 or 100 years, if you were an 8, probably not. But now, maybe, because the barriers are lower.
Okay, one other question. Yes. Your opinion as a psychiatrist, which is preeminent, not you, but the question. Which is more important, the mind or the body? And can you disassociate the two?
I don't think you can. Specifically for transgender folks, I don't think it's possible. The body is rejecting of the mind and kind of their experience of development, and their experience of who they see themselves as is rejected by their life experiences on the playground, in their families, in their photos, in their dress. I don't think it's possible to dissociate it for most people. Not everybody who's transgender has distress in their body.
And are there any studies that show the physiologic health outcomes of those people who go through medical interventions?
Yep, we have good longitudinal data that's coming out of Holland. So most of the good data that we have comes from places that have nationalized healthcare settings that have followed these folks and have kind of 1 or 2 clinics where they have to go for treatment. So there's good data coming out of Holland that's about 30, 40 years of folks who've been on hormones, which is positive. In kids, no. We have our first NIH study, not me, but our field has our first NIH study that's looking at the long-term impact of puberty blockers over 20, 30 years. But other questions? Okay. Well, thank you. I'll be up here for a little if you have questions you didn't want to ask in front of people. So.
I have a question on the phone.
Thank you.